Hi, listeners.
Hello. Welcome to the MedInsights Unleashed podcast
With your hosts,
Z
and John. Good evening and good morning to our listeners at MedInsights Unleashed. My name is John Collins. I co-founder with Zara Ramji. I know our followers have been with us now for over 14 months, and we have been covering several topics, especially focused on cancer, but in other areas as well. I was very fortunate to go to ASCO this year. ASCO stands for the American Society of Clinical Oncology, where we have over 40,000 oncologists attending to present all their research. Unfortunately, Zara can't be with us tonight, so she sends her apologies. We have Dr. Danny Rischin with us, who is the lead investigator for a study called CPOST, which is an adjuvant study in head and neck cancer, and CPOST stands for Cemiplimab in postoperative setting trial. Danny is a fellow Australian. He's a medical oncologist researcher, and he's a professor at the Sir Peter MacCallum Department of Oncology at Melbourne University. He's also has over 300 publications. He specializes in skin cancer and the impacts of skin cancer. So I'll get Danny to really talk to you about himself, and then we'll kick off about the CPOST study, which is the first study ever to have disease-free survival post-adjuvant therapy. So this is a significant step forward in head and neck cancer, everyone. It's an amazing study, and we have the lead investigator here to talk about this study. Over to you, Danny.
Thanks very much, John. Thanks for the invitation. Pleasure to be talking to you today. So, as you've heard, I'm a medical oncologist based in Melbourne. I'm from Melbourne originally. I did my training in Melbourne. I'd also spent a few years in Toronto, in Canada, and really came back, to Australia in the early 90s, and have really been at Peter MacCallum since then, and largely focused working in the area of head and neck cancer, and in more recent years in skin cancer, and really focused both in terms of my clinical work as a clinical researcher doing trials, and also translational work in the laboratory. We've been particularly interested. I've been particularly interested in developing new treatments, better treatments for patients with skin cancers, particularly what we call cutaneous squamous cell cancers, one of the more common skin cancers. It's a neglected area of medicine, but we've been focused on trying to develop new treatments and improve the outcomes for these patients.
How prevalent is this disease globally?
So I think when one thinks about skin cancers, one can think of melanoma and non-melanoma skin cancers. And melanoma skin cancers are both the squamous cell cancers and the basal cell cancers. And they are much, much more common than melanoma. In fact, it's estimated in Australia, for instance, it's estimated that 70% of the population will have at least one non-melanoma skin cancer in their lifetime. And many patients have multiple skin cancers. The difference between the non-melanoma skin cancers and melanoma is that the cure rates of the great majority of non-melanoma, including squamous cell, are much, much higher. Probably 95% of patients with squamous cell cancer are cured with surgery, often simple removal. But they're very common. You have 5% that have more aggressive disease, but still a significant number of patients. The difference in melanoma is that the proportion of patients in melanoma that may develop metastatic disease is much higher, but melanoma per se is nowhere near as common as the non-melanoma skin cancers. And so a lot of our focus has been in that group who aren't cured with surgery and sometimes postoperative radiotherapy, and trying to work out previously done work in the patients with even more advanced disease, so patients with squamous cell carcinoma of the skin that has recurred and is not amenable to any more surgery or radiotherapy, or has spread so that they've got distant metastases. And that led to the approval of anti-PD-1 drugs, in particular Cemiplimab, for patients with very advanced metastatic disease. And that's standard of care approved around the world. And approximately half the patients have a good sustained response to that. And really that led us to think, well, maybe we could take this drug, the immunotherapy drug, anti-PD-1s, Cemiplimab, and use it in an earlier stage of disease to see if we could improve the outcomes and prevent these patients from recurring.
There's dermatologists that treat, there's a multi-centered approach. What is it that drives these patients into the study, into your research center at Peter Mac and all the other centers globally?
Yeah, so I guess hospitals are all set up a little bit differently, but these days cancer care in larger centres is multidisciplinary, so we have multidisciplinary meetings. These patients with skin cancers, most of them, probably 80%, arise in the head and neck. So they're often managed by our head and neck surgeons. They're also managed by our skin surgeons, general surgeons, plastic surgeons. And we actually have a combined meeting once a week where all the surgeons, the radiation oncologists, medical oncologists, pathologists, radiologists, we all meet and discuss cases. So these more advanced cases are presented there, and we discuss what the best treatment options are. And certainly, whilst these patients were having standard surgery and radiotherapy, if they then meet the criteria for the trial, they were then referred to me to discuss whether they wish to participate in the CPOST trial.
415 patients were in the study and met the criteria. In this criteria that you had high-risk patients and others with nodal and non-nodal involvement. What is a high-risk patient for this particular study? What do they look like?
So I think one of the problems has been identifying the patients who need extra treatment, who don't do well with surgery and radiotherapy. We did a previous trial, which was actually called the POST trial, which I co-led with my colleague Sandro Poseju, who is also at Peter Mac now. And this trial was actually just looking at the addition of chemotherapy to radiotherapy in these similar group of patients. And that was a negative trial. But one of the things that we did up with the data from that trial is we did a sophisticated analysis called it's called a recursive partitioning analysis with our statistician, Matthias Bressel. Basically, without going into detail, it's a complicated statistical model in which you try and identify how different groups of patients that were in the trial did. So essentially what we're trying to do, who are the patients that do very well with surgery and radiotherapy and don't need extra treatment, and who are the patients who actually did poorly with surgery and radiotherapy. And so we're able to identify that there were groups of patients that were in the original POST trial who did exceptionally well, and there was no reason to be looking at giving them extra treatment. What we did find we identified a group of patients who were at much higher risk of recurrence. So we estimated that we found a group that had about a 45% risk of recurrence. And these were patients who had larger lymph nodes, usually in the neck, and as well as having the cancer not just being in the lymph nodes, because the cancer often spreads from the primary to the lymph node first. So it was not only in the lymph node, but it spread beyond what's called the capsule of the lymph node. And that's regarded as a poor prognostic factor. And indeed, in our analysis, we were able to demonstrate that this group only had about a 55% survival 3 years. Recently published that information, but obviously been aware of it for some time. So we actually used that information in the design of the CPOST trial. So what we wanted in CPOST was to have a group of patients who were at very high risk. Because if we were going to show benefit from adding immunotherapy, we needed to have a group who were at significant risk of relapse. So we identified this particular group from our previous study, plus we added some other groups that we knew had a poor prognosis from the literature. So we divided it up into the high-risk features that they had to have were either what we call lymph nodes, so the cancer spreads from the primary to the node. So they either had to have this large nodes with extension beyond the capsule, or they had to have 3 or more lymph nodes, or they had to have features of the primary that were associated with a very poor prognosis. So spread into what we call soft tissue deposits in between the primary and the lymph node, very extensive nerve involvement, invasion into bone, or recurrence of the primary after previous treatment with other adverse features. All patients enrolled had to have at least one of these features. And in fact, the most common feature on the study was having that half the patients had lymph nodes that were 2 centimetres or were large and had extended beyond the capsule.
In these patients, you bring up so many questions. Is there a biomarker for these patients? Is there some way of identifying these patients in advance?
Not at the moment. We have a lot of studies going on at the moment to try and identify biomarkers and obviously how we can predict which patients are at highest risk of relapse, but we don't have anything at the moment. And the current staging systems are not, for the purposes of identifying patients for this sort of treatment, are not very good. That's why we came up with our own new risk criteria, which actually panned out very well. The group that didn't receive immunotherapy in a CPOS trial pretty much behaved exactly as we had modelled or predicted based on our estimates of their risk of recurrence.
Well, that's an amazing analysis. So let's get into the actual CPOS study results. As I said earlier in this study, it's the first study ever in the adjuvant setting to be shown a positive disease-free survival at 24 months. Just previously to your presentation, there was a presentation on Keytruda, the 630 trial, a similar disease patient group, one trial positive, one trial negative. How does this happen? What made your study different to 630?
Look, I think 630 hasn't been published yet, so the information we have is just from the presentation. I guess to start with, what are the strengths of this CPOS trial were that it was well designed. We had very robust identification of the high-risk patients. We had very clear criteria of what an event was, so what a recurrence was. One has to be careful in these trials because these patients often have multiple skin cancers, and you have to be careful not to call it a separate new small second primary tumour as an event or a recurrence or confound your results. So I think there were some differences in the trials. Clearly, when you look at what was presented for Keynote 630, they had a large number of deaths that were not related to recurrence of disease. I think in that study, there were something like maybe just under 50 deaths that were not due to recurrence. We had about 10. That's a very big difference. So I think they did see some difference in recurrences, but they had many more deaths in the pembrolizumab, and in fact saw overall survival in their study actually favoured the placebo arm, which is not the case in the CPOS trial. So the results in our trial are that we saw a very large difference in the primary endpoint, which was disease-free survival. So disease-free survival means any recurrence or death, whichever occurs first. And at 2 years, we had a disease-free survival of 87% versus 64% with the placebo arm. So that represents, a 69% reduction in the risk of recurrence, which is quite dramatic. Survival curves were very far apart, and you could see when you look at those survival curves, what happens with patients that don't get immunotherapy, is get the standard treatment, is that many of these recurrences or deaths occur in the first 12 months, and you pretty much prevent that from occurring with the use of Cemiplimab.
Can you just explain to the patients what disease-free survival actually is?
Yes, so we're looking over time at patients who who remain alive and haven't had a recurrence of the cancer. So the cancer hasn't come back. So when we say disease-free survival of 87%, that at 2 years, that means 87% of patients are alive and the cancer hasn't come back. The curves, as I said, they separate very early and they remain apart. With the follow-ups, obviously limited, but certainly up to 3 years, we can see that at the moment. And obviously, we'll be following these patients further, long-term outcomes.
In the patients and when you're administering Cemiplimab, how is it tolerated?
So, obviously we have a lot of experience with Cemiplimab and other anti-PD-1 immunotherapy drugs. As when you give the drugs by themselves, they're well tolerated by the majority of patients, but you always have the risk of what's called immune-related side effects. So obviously these drugs work by enhancing your body's own immune response against the cancer. But sometimes that impacts on normal tissues, normal organs. So you have about a 10% risk of significant immune side effects. So we saw that in this trial, but it was very similar to what we see in other settings. We didn't see there was nothing in this adjuvant study that was any different to what we would have expected. About 10% of patients on the Cemiplimab arm had to stop treatment because of side effects, which is about what we would expect from what we know of these drugs in other settings.
From an adverse event perspective, were there groups like elderly or younger age? I know that 84% of these patients were male, which was interesting.
Well, I think first of all, to say that this is a disease that predominantly occurs it's more common in males, it's more common in Caucasians, fair-skinned people, and most commonly arises in the head and neck. So it's about sun exposure, really, and it's about sun exposure in people who have fair skin, often living in hot climates. In Australia, there's a reason why Australia has the highest incidence of this cancer in the world. There are a lot of fair-skinned people living in a hot climate, and you can actually see by the by that if you look in Australia or the US, it's high incidence throughout, but it's latitude related. So the further you get away from the equator, the lower the incidence, the higher, close to the equator, the higher incidence. You can see that gradation as you go from the bottom of Australia, right up to the top in Queensland. So the type of patients that are involved are very typical. This is a disease that's more common in the elderly. We do see it in some younger patients, but you saw the median age was 70, and we had patients up to 95, and we do treat a lot of elderly patients if they're otherwise not reasonably well. There is a general impression that immunotherapy side effects might be a little bit less in patients who are older rather than younger, but everyone's has we still see the side effects that occur.
So with these patients, when we're talking about their response, was there better responders than others?
No, I guess this is an adjuvant study, so patients don't have, when we start the treatment, they don't have any disease that we can see or measure. So what we're looking at is the cancer coming back. What we did do is that we had a whole number of pre-specified subgroups to look at to see if the benefit occurred was limited to some subgroups. In fact, it wasn't. We saw it across the board. So we saw it, irrespective of age, sex, and we saw it in country. It was obviously conducted in 16 countries across the world, but we saw the benefit in 3 different regions that were involved: head and neck versus not head and neck, and also the group I mentioned before, the high risk groups, both in the nodal and non-nodal group. And finally, in some cancers, the effectiveness of immunotherapies can be correlated with the expression of a marker called PD-L1. And in some cancers, uh, it guides treatment, whether you give treatment or not, or how you manage the patients. But what we found here was that the benefit of giving cemiplimab was seen both in the patients that were what we call PD-L1 positive and PD-L1 negative. And that actually is consistent with what we found in this same disease in the metastatic or more advanced setting, where these patients respond irrespective of PD-L1 expression. It's different from some other cancers where, for instance, if you're PD-L1 negative, your chances of responding are very low. That's not the case in this disease.
I'm glad that you brought that up, because that's a big discussion in some of the other tumours that we cover, and the response is very, very specific about if you're PD-L1 positive or negative. As you just said, the response can be quite dramatic actually in those patients, especially in colorectal cancer now in the earlier setting. It's quite amazing. If there's a patient out there has squamous cell carcinoma, they've been to the dermatologist, what's the steps that they should be taking in the treatment?
Yeah, because again, just to step back, you remember that 95% of these very common skin squamous cell cancers are easily treated with local treatment, usually often surgery alone, whether that's done by the dermatologist or a surgeon. I think they will know to refer on if they find adverse features, either clinically of the disease, they find that the disease has already spread to lymph nodes, or they get a result back from pathology after they've removed it. Then they would refer on to other, for other treatment. But that's, again, remembering in the broader picture of everyone who gets these skin cancers, it's a small subgroup. It's just this is such a common disease that we could accrue 415 patients, and we see quite a lot of these patients. But keeping it in perspective, the great majority of people don't need to panic. They've got a skin cancer, they get it removed, and they're probably going to be fine.
Maybe they should use a lot more hats and sunscreen and before they actually go out in the sun and get these things.
Well, I think that's very much the case. Sun protection. We're seeing a lot of these skin cancers in elderly people who grew up at a time where there was no awareness of sun protection, where people weren't using, sun cream or hats. And clearly, hopefully, we'll see less of these cancers in future generations with better sun protection.
The other question that I do have for you is it's going back to disease-free survival. One of the regulatory endpoints that everybody wants to know about is overall survival. You talked about this was a very, very positive study at 24 months. So you've got data out to 3 years. One thing about this study is it allowed crossover from the placebo on progression at 24 months. So how does this work out from an overall survival perspective?
So, look, I think one of the things about this analysis is that we had 4 planned analyses, and this was the first analysis. That was where we anticipated 50% of so-called disease-free events would have occurred. We weren't obviously very pleased and that we saw such a dramatic result with the first analysis, but what it does mean is that the overall survival data is relatively immature. It favours cemiplimab, but it's not statistically significant. We'll need to follow for longer. Now, patients on the placebo arm, when they relapsed, could cross over to receive cemiplimab. So we know that probably 40 to 50% of those patients will respond. So clearly the magnitude of any overall survival benefit will be lessened significantly by the fact that many patients will be salvaged by treatment in the relapse setting. Whether there is an overall survival benefit, despite that, we'll just have to wait for longer follow-up to see.
Many more presentations to come on CPOS then, obviously.
There are a number of things we we need to still report on, including the incidence of second primary tumours. So there's more to come.
When we were talking about the great results, your dosing was 3 weekly for 12 weeks, and then you went on to 700 milligrams every 6 weeks. Made a difference in the outcome?
So we started off giving 350 milligrams every 3 weeks for the whole 48 weeks, but there was an amendment in which after 12 weeks we switched to 6 weekly of 700, really just for patient convenience. The modelling suggested that we'll get similar efficacy, and in fact, in exploratory analyses, we showed that the effectiveness was similar with the 3 weekly switching to 6 weekly versus 3 weekly throughout, and the side effect profile was similar. So either is acceptable, and obviously having it 6 weekly, it's advantageous for many patients.
Agree. It's less time coming to the hospital and more time to enjoy life. That's fantastic. I thought that was a different dosing than what you saw with 630. So that was an interesting outcome.
Pembrolizumab can also be given 6 weekly.
What are the 3 key things that you summarized from a patient perspective out of the study?
Well, I think, first of all, the study really reinforces the criteria we use to identify a high-risk group, the patients that are at risk of relapse. So after patients have had surgery, we are now able to identify the patients that are at risk, where previously there was some uncertainty about that. So we validated that, and that's very helpful for patients and physicians to know if they're in that group or not, because if they're not in that group, they need additional treatment. So, and following on from that, if you're in that group, then the results clearly show the benefit of having adjuvant Cemiplimab in terms of preventing recurrence. And obviously, there's a process to go through here. The drug has to be approved in this indication based on the CPOST results in various jurisdictions, and that hasn't happened yet. But assuming it gets approval, then the patients that fall into this category will be having a discussion with their physician about the pros and cons of having adjuvant treatment to prevent recurrence versus the alternative of not having it and waiting to see if they recur, and then trying to salvage the situation and having immunotherapy at that point. One of the things about this disease is that particularly the local regional recurrence in the head and neck is really associated with considerable morbidity, and often patients need multiple interventions with disfiguring surgery and a lot of discomfort and morbidity. I think there's a lot to be said for preventing the cancer from coming back.
So I've got 2 questions following up from what you just said. One of the areas that immunotherapy is moving into is the neoadjuvant setting. Is this a setting SCC?
Yeah. So neoadjuvant, as you rightly identified, is a very promising approach. We've seen great results in melanoma, for instance. We collaborated with Neil Gross from the MD Anderson and published in New England using neoadjuvant treatment in a single-arm study in patients with cutaneous SCC, and really showed some very impressive results. So, it's about 90 patients, and 55% of these patients with 4 doses had absolutely no cancer left in their specimen when they went to surgery. So neoadjuvant treatment offers the possibility for many patients, of giving just 4 cycles, perhaps less surgery as the cancer shrinks, and often potentially avoiding radiotherapy as well. I think neoadjuvant treatment has a lot of potential. You obviously can't really identify the high-risk patients as easily, so you end up treating a broader group of patients, but it has a lot of potential. And there is a phase 3 trial now being led by the NRG in the United States, a collaborative group in which we're collaborating with, which is looking at formally testing the neoadjuvant approach. But obviously the results of that are several years away. So in the meantime, we've got, in terms of standard of care, we've got CPOST, but neoadjuvant is definitely an exciting approach to be investigating, which may further refine how we manage these patients.
Oh, that's amazing. And what a fantastic results that you're getting in that neoadjuvant setting. That's incredible that patients are responding so dramatically to this therapy.
I think it reinforces that this cutaneous squamous cell carcinoma is probably one of the most sensitive diseases to immunotherapy of all. No one else, that the high pathologic complete response rate, I think just reinforces how responsive this particular disease is in immunotherapy.
Yes. Can you just explain to the audience what CR, complete pathological response is?
You operate, you remove the cancer, you send it to the pathologist, and they methodically look through the specimen trying to see how much cancer is there, and they can't find any, not a single cell.
It's amazing. That's amazing. Congratulations on this. Is there anything else you would like to tell these patient caregivers, investigators, doctors that are listening to us now about this study that we haven't already covered?
No, I think we've covered the key things in the study. I think it clearly showed it's a clearly very positive study, clear benefit, well tolerated treatment, and a good option for patients and physicians to consider.
So, Danny, on behalf of MedInsights Unleashed, Zara and I want to thank you for all your time this morning for you, tonight for us. So, on behalf of MedInsights and all our listeners, we're very, very proud to have had this conversation, and thank you.
Thanks very much, John. It's been a pleasure talking to you, and look forward to.
Thank you. Bye. MedInsights Unleashed disclaimers. This podcast is for general information purposes only and should not be considered healthcare advice in any way. The podcast is not intended to replace professional medical advice. The use of the information and material linked to the podcast is at the user's own risk. MedInsights Unleashed is not responsible for any losses, damages, or liabilities that may arise from the use of the podcast. Importantly, please consult your healthcare provider for individualized guidance and treatment. Thank you, and we look forward to you being with us on the next MedInsights Unleashed podcast.